Every year, millions of Americans end up in emergency rooms and hospital beds for conditions that could be treated just as well and far more safely in their own homes. So why does care still default to the most expensive, most disruptive setting possible? And who's actually doing something about it? Welcome to CareTalk Executive Features, a series where we spotlight innovative companies and leaders working to advance the healthcare field. My guest today is Lon Hecht. He's CEO of Care2U, a New York-based provider of ER and hospital-level care in the home. With 25 years of experience spanning pharma, telehealth, value-based care, and home-based care, including his time as SVP of Growth at Optum Home and Community Care, Lon brings that rare combination of startup hustle and enterprise scale perspective to one of healthcare's most important and fast-moving shifts. Lon, welcome to Care Talk.
Thank you, David. It's great to be here. I'm a big fan.
Outstanding. Lon, you spent about 25 years, we'll just round it, moving across some of the biggest platforms in healthcare. I'm talking pharma, telehealth, value-based care, Optum. That's the biggie. So what drew you to home-based care, and why are you betting your next chapter on that?
Well, I think home-based care is really what the next chapter is. That's where care is really starting to move. So I'm a big fan of skating to where the puck's going to be, not where the puck has been. So I think that's one big thing about it. The other one was when I was at Optum in Home and Community, the division, I felt like I had a need that was being underserved. We were selling to external payers, taking on full capitated risk. And one thing that Optum's very good at would be things like star ratings and risk adjustment and things like that. But when it comes to levers to actually pull in the expense management side, they're few and far between. So I had a pain. I actually got a call from the investors that are behind Care2U. They explained what they're doing, and it just really resonated with me. And it just felt like it absolutely was my next chapter.
So I'm sure that a lot of people, in your seat at Optum previously and other places around the country had looked and said, yeah, this is a real problem. I wish someone would do something about it. And I understand, then you went to Care2U for something new and different. And I'd love to hear what's different about the model, but also what makes it better.
Yeah, sure. So think of us as kind of like a medical group that brings high acuity care into the home. We get a referral, whether it's from a patient, a provider, care manager, home health, wherever that may be. We dispatch into the home a clinician, typically within 2 to 4 hours of getting notified, and we work up that patient. And then we bring an ER physician or hospitalist on concurrent telehealth. So you have 2 providers in a visit. So the models that are out there today, I'd like you to think about it in 2 different ways. On one side, you may have urgent care at home type of vendors. We are higher acuity than that. We're next level higher acuity. And when you look at them, they're typically escalating 25 to 35% of patients to the ER. We are next level higher acuity, and we're escalating closer to 10% to the ER. So the value proposition is very different. But then on the other side, you have these hospital at home programs. And I think hospital at home is really interesting, but it was more of a COVID capacity play, and it's hospital controlled. So what happens is a patient actually has to go to the ER. They have to put all that time into the ER, meet clinical criteria. Then an administrator has to decide, I'd rather send them home than fill that bed. And that just doesn't happen that often. So what we've done is we've really turned this model on its head. And what we do is the ER at home or ED avoidance visit is really the tip of the spear. We go into the home. If we can treat that patient in one visit, perfect. If they need ongoing care and they hit MCG criteria, we can do a full admission. Now, keep in mind, it's not a hospital admission because we're not a hospital, but we can admit them to our service right in the home and treat them as if it was a hospitalization in the home. And what's really beautiful about this is if you look at like the hospital at home waiver model out there, there are some cost savings, but not very substantial. And it's really just for fee-for-service Medicare. Our model is for all payers. It's for all risk-bearing entities. We've really aligned ourselves more with the folks. If you think about healthcare, you think of follow the dollar. Who controls the dollar? Payers, risk-bearing providers, they tend to control the dollar. So what we're doing is we're finding a way to provide this care to them in the home, and we do it at a fraction of the cost. So if you look at Medicare, our costs are typically about a third of what a hospital utilization would be. If you look at commercial, because it's so much more expensive, it's closer to a sixth of the cost. So it's a very different model that we do, and we bring really high-level capabilities into the home.
So, Lon, I know a lot of people have had this experience with themselves or with older relatives or something. So let me actually just walk you through a scenario that I was dealing with recently, and maybe you can talk about what might have been different, if anything. So
Sure.
I was dealing with some older folks in their mid 80s, husband and wife, and the husband has the sort of things that someone in their mid 80s might have dealt with, has had cancer in the past, various things, and we had kind of a little bit of a fever, wasn't feeling well. It was about 3:30, 4 in the afternoon. They live in a senior home that actually has a medical clinic with an NP in it. They didn't want to call that person because they thought, well, if they do call him, they don't really know him, and that we couldn't get downstairs so easily, and then they're probably going to get transported anyway. So they sort of tried to wait it out, and then a couple hours later, the wife basically said, I got to call 911. And they ended in a hospital. And they did things that I would say are done in a hospital that you wouldn't do, like, that you probably can't do. Like maybe you can, because a couple CT scans, blood tests, a few things like that. And, through my intervention, ended up being discharged at 2 or 3 in the morning rather than, being admitted and then potentially having some of the issues that this person's had when they're in a hospital for a long while. So I've just given you the outline, but I can tell from your space, it sounds similar. So can you help me out with this? What might be different?
Yeah, absolutely. So we do work with a lot of senior communities, assisted living communities, things of that nature. They typically have either providers on staff or they have maybe home-based care providers that would come in there. And they have certain capabilities, but they typically don't have urgent to emergency level capabilities in there. So in a case like this, a very simple call to Care2U, we could have been in their community, in their room, 2 to 4 hours, have been able to manage things, stat labs, we can do imaging, we can do oxygen concentrators, we can do all kinds of things in there to be able to manage that patient in the comfort of their specific room, and very likely would have avoided that escalation to the ER. And what gets really complicated is when a patient goes to the ER, that's one step. But very often, especially when they're seniors, they're going to get put in observation level care, at least, if not a hospitalization. And it just goes on and on and on. And then they're around a lot of sick people, which is the last place you want to be. So we do work with a lot of communities. We work with a lot of home health providers. Believe it or not, we work with a lot of hospitals because there's a lot of value that we can provide for them. I'll just mention one. So readmissions are such an issue, right, for hospitals. And if you think about the way they approach things now, it's more of like a population health based approach. They have to pay a lot to try and figure this out. What hospitals can do is if they on a Medicare penalty diagnosis, they could send a patient home with a bracelet that says call to Care2U if you have any kind of urgent need. We can deploy in the home only on those that have needs. We could probably stop about 90% of those readmissions from happening. So it gets very specific. So there's a use case for everyone. It's just knowing what is the value we can provide to that specific person.
And would the hospital be interested in preventing that initial admission or ER or observation visit, or only in the readmission penalty part of it?
So I think there are a number of different things. It depends on the hospital. So I don't want to pretend that we are absolutely in alignment 100% of the time. But when they are in value-based care contracts, this gets really interesting to them because the cost is substantially lower. So they really like us for their value-based care lives. They really like us for readmissions. They like us for their employees typically. They also like us in the sense that you have patients that end up getting admitted and they're in a bed and they're taking up a bed and they're there for 3 days. Your DRG is safe. The problem is you may have them there 5, 6, 7, 8 days because they need twice a day IV antibiotics or Lasix or things like that. We can manage that for them in the home and they can turn that bed. So there's a lot of value that we can provide for a hospital. It's just aligning on what's important to them. I don't want to pretend that it's always going to make sense, but I do think, and I'm not going to get into depth in this here. I do think there's a model, and I believe that I can do this, where I can pull the payer and the hospital and Care2U together to put a model, a line that makes sense for everyone. I think there's a lot of value that can be derived from that. I think that's where the market will go. I think it's a couple years out, but I think in New York, especially since we've got such a good footprint, it could be sooner. So I think we'll do some really interesting things soon.
I want to come back to something that you started off talking about, which is hospital at home broadly and where it succeeded and where it hasn't. So I've been hearing about it for a long while. It sounds appealing. It's been building for years in a way, but the adoption's been uneven or low. You mentioned it being kind of a, capacity issue for COVID, and it's not really hospital at home. It's like part of hospital at home, or hospital and something else that's going on. But what is holding this movement back? Is it regulatory, cultural, financial? Just some things that the hospitals are typically doing. Why haven't we seen it go further?
I think it's all of the above. So I think cultural, there's an educational component that needs to be done out there. I think it's regulatory. That hospital-based model that was the CMS waiver program, there was so much uncertainty with that. Now, keep in mind, once again, that is for fee-for-service Medicare only. There was a lot of uncertainty about what was going to happen with that model. So I think that held back adoption. The other thing is for payers. Where do payers sit in this? What is the value that they're getting derived, right? Hospitals want to make as much money as they can on hospitalizations. On a hospitalization, payer wants to pay as little as they can. There's got to be a happy middle ground on what this can do. And I do think that this home-based care or this home-based hospitalization could be the way to really solve this and really unlock a lot of value for folks. So I think it's a ton of things. I think it's, the financial, like who wins in this? And then I think it's like education. How do people learn about this? And then I definitely think regulatory had a lot to do with that. And each state is very complex with their regulatory, the different criteria that they have in place. So just because we've been successful in one market with one model doesn't mean when we move to another market, there's now going to have to be a little tweak to the model because every state's a little bit different.
As I understand it, the company was founded by emergency room physicians who would kind of watch patients waiting hours and hours in an overcrowded ER. And by the time they got to them, it's sort of like, well, you didn't really need to be here in the first place, certainly not for admission, but maybe even to be seen in the ER. Do you have a sense, if we've all experienced it, I gave you one example, current, recent one, but help me get an understanding of how big the problem is and what the costs are to the system.
Yeah, well, good question. The problem is huge. One, because it clogs up ERs, and we all know I don't want to speculate on what ER wait times are, because no matter what I say, somebody's going to argue with it. But at the end of the day, they are way too long, and they're clogged up with so many things. I bet 45+% of the things that happen in the ER really don't even need to be in the ER in any way, shape, or form. Huge opportunity. That if you look at just, let's say, 45% of ER visits, and then let's say 15% of inpatient admissions, you're probably looking at a market size of close to $150 billion across the country. In New York alone, probably $12 billion. So it's pretty significant. So I look at it as the right place of service is so critically important for anything that you're doing. And we can really right size that place of service. And in doing that, you can free up the emergency room for the things that actually need to be there, that people that are coming in with these really, truly high acuity needs can be treated in a timely manner. And the other thing is, I think it helps payers also with some of their providers or hospitals with some of their case mix as well. Being able to put folks in that actually need to be there, I think there's some value for that, especially in these overcrowded hospitals.
We had done some work a few years ago here in the Boston area where I'm located, trying to do something about the number of unnecessary emergency room or hospital visits because the cost is high and so on. And so a lot of it was saying, well, physicians have inconvenient hours and it's hard to make an appointment, hard to get in touch. And so what they found, though, is that when they made it more convenient and had even weekend hours or evening hours and it was easy to get in, it didn't actually really solve the problem. And sort of speculation was, well, Mass General has all these ads up about how they're, MGB, great hospital and get the best care. And when people are sick, it's sort of like, well, I'm going to go there one way or the other, even though we know it's bad if you're actually running it and people don't need to be there. So I think I had an assumption that, yeah, it's a problem and everybody recognizes it. Nobody wants to be in the emergency room, but people seem to quickly jump to that anyway. Do you see something similar?
I think that people are wired that way, but I think that there are things that we can do with that, right? I mean, if you just look at the payer world, so first of all, we contract with a lot of payers and a lot of risk-bearing entities. I think the next step is slotting Care2U, and I'll just give you an example, where when you have your insurance card, it's $15 for a PCP, $30 for a specialist, $50 for urgent care, $75 for Care2U, $150 for ER, something along those lines. So people understand that there are progressions of care. I think that there are things that you can do about that. I also think that when you look at a payer risk-bearing entity, they have patients that are polychronic or have just specific chronic conditions. Education campaigns, if you're CHF or COPD and you're utilizing, the ER in the hospital all the time, there's a lot of proactive education that can be done to get people to understand there is a better option for care, because who wouldn't rather have something like that treated in their home than in the hospital, right? So I think that there are a lot of things that can be done there, but you're right. People tend to default, and it's going to take a lot of time for an education campaign. But then you look at something like urgent care, right? Urgent care, I think, started off with its heart in the right place, and then all of a sudden became a little bit of a way to disintermediate, in a sense, PCPs. And that's not what we want to do. People go there for things that they should go to their PCPs for. So I think really slotting that at the right copay level and the right education is critically important. And I'll tell you one thing we do. When we get a call from a patient or from a provider or anyone, we're going to understand what that primary complaint is. If it's too high acuity, we're going to get them right to the ER. But if it's too low acuity, we're going to try and get them back to their PCP or urgent care provider in network, because that's where the value lies. My goal is to be a really good partner and a good steward of the MLR of my partners. And I can't be seeing a bunch of sore throats and things like that in the home. That just doesn't work, right? So I think there's a lot of education that can be done on the front end. And then when they call us, we need to be able to educate them as well.
So a pet peeve I've had is when you call pretty much any healthcare provider, and some payers, they'll say, wait, we're not around or whatever, but, if this is a medical emergency, hang up and dial 911. So it's not as though they say, well, see, if it's really serious, do this, but, so they just basically, I'm not here, I don't want to be responsible, call 911. So there's a lot of that. And I wonder where, if you look and you say, let's get into this triage aspect a little bit more, because sometimes, it's like in this example I gave of the elderly couple before, seemed okay, seemed manageable, and all of a sudden it went from the person then starts to panic, maybe because the fever, went up. Are they still going to go and just do 911? Or is there actually a way to intervene and get it at the right level? Or do you still have to be very conservative?
Yeah, well, I think that if you have an option like a Care2U up front, that allows people to make that decision a little bit sooner, because the problem is, and I'm sure you've done this, I've done this, I put things off, hoping they're going to get better, and they get worse. And then all of a sudden I have to run to this worst case scenario situation. And if you call 911, there's a good chance there's a transport involved in that. I mean, that blows up the cost model right then and there. I don't even factor that into any of my conversations in any way, shape, or form. So I think giving them options that make sense, that they can actually react to sooner, makes sense. I can see, and I'm not saying we're doing this right now. We do partner with, typically we will get embedded when we work with a payer into their telehealth provider as an escalation point, their nurse triage line, things like that. But I could see a world in the future at some point where we consider becoming a nurse triage type of vendor, because we're actually someone that can be in the right place at the right time and do the telehealth or do the in-person care or do those kind of things to be able to do it. Not saying we're going there and if you look at most early stage companies, a lot of the reason they fail is they want to be too many things to too many people. And I don't want to do that. But it's something that I do think about in the back of my mind. And if I had the right payer approach me at the right time about that, I think it would be something I'd be willing to have a conversation about. But it would have to be the right time.
Speaking about early stage companies and successes and failures, I know you're a fan of podcasts, and you used to be a co-host before you decided to apply yourself more specifically. And I love the name of your podcast, The Healthcare Grind. I mean, that could every podcast could be called that, but the focus was on the early stage founders and what it really takes to build something in healthcare. And I was going to ask you about kind of the most common mistake that you see, and I think you just mentioned trying to be everything to everybody, but any other kind of things that you heard from founders that are guiding your current experience?
Yeah, so I do think the all things to all people is a really hard, because there are so many things on a day-to-day basis that come to me that could be really good moves for us financially, but take us off task. So I think one is being really focused is very important. But I think the other thing is too many early stage founders want to boil the ocean. They want to get out there and they say, look, my model's doing really well here. I want to be in 50 markets. And I just don't think that works. We have been really deliberate about doing a really good job in probably one of the toughest healthcare markets in the country. Lower New York it's impossible. I mean, it could take you an hour to go a block. It costs you $50-$60 every time you want to park. It costs you $45 in tolls. Like, you've got all these kind of things. You're getting, tickets like crazy. It's really difficult. You've got regulatory challenges that you just do not have in other states. So I wanted to be really mindful in building something that is very scalable, and we've got our clinical model right. We've got everything lined up in the right way. Now we're at the point. And we're well backed by a great firm, and I feel wonderful about that. But we're probably about a week or two away, and maybe this episode will come out later, from probably kicking off some additional fundraising, because now I think is the right time. We built the right model to raise some additional funds and move into some other markets. And I think one thing that's interesting about this emergency, like ER at home and hospital at home kind of spaces, there really isn't a national player. They're very regionally focused or really small market focused. And that's challenging because payers live in this world where they want to do everything from like a national level. And it's not the right way to look at this right now, because if you're going to wait for that, you're going to be waiting like a while. Right. So I think now is the right time to do that. And it's been staying really focused on building a good product, a great product. Now we can go and move into other spaces.
All right, so I'll throw some old stuff out there. So, if you look at New York, which I'll agree is a tough market and just tough in a lot of standpoints, is it this sort of, if you can make it there, you can make it anywhere, or you have the issue of like, will it play in Peoria? In other words, what you're doing there, overcoming some of those big barriers, do you end up doing things in a way that actually don't make sense in a place where there isn't traffic? You can just pull up and park, and not everybody's as aggressive or whatever, however you want to describe. They're not all Yankees fans, for one thing.
I'm not going to comment. I grew up in Philadelphia, so I'm probably no one's friend. So I'm just going to leave that one there. No, I think you're right. If you can make it here, you can make it anywhere. I believe that. I do think that healthcare is very local. So you want to be able to stand up teams that are local in that area. I don't think that it doesn't play well in a Peoria or anywhere else, but I do think you need to have density of patients for it to make sense. You can't have a 3-hour drive time between patients, or else the costs would be really high. And we have to be mindful. Now, payers have to decide what their needs are. If there was a need and it was more rural and there was a way to financially make it work, then we could do it. But we need to be very efficient in what we do. Keep in mind that when you're providing high acuity care in the home in 2 to 4 hours, in a way, you have to be somewhat inefficient because you always have to have an extra capacity on the side. So it's being as efficient as you can with a little inefficiency baked in case it flexes, right? So I think the lesson in New York plays really well. And I think we could do this in just about any market, but I think density is important for us.
So you mentioned payers, Darren. Let's talk about that a little bit, because
Sure.
Payers certainly get a bad name, and I'm not saying they don't deserve it in a lot of cases, but they've got this really financial incentive to keep patients out of the hospital. And so on the one hand, you'd say it makes total sense. You can show a good ROI. They'll lean into it. On the other hand, there's a concern that they have about kind of denying care or putting people in the wrong kind of places. So that started probably with HMOs and saying you have to get out right after you give birth and stuff like that. And so how do they handle it? Because an argument could be to say, well, I used to go to famous hospital number 1 or 2 in Boston when I had a problem, and now they want me to go to this this other thing and actually stay home and not go. So what is the dynamic like with payers, and is it changing?
So payers are really leaning into this market. And that's kind of my background. That's what I've been doing for the last 20 plus years, the payer world. And I think that's what makes us different is I'm actually able to go and speak payer, right? And I know what makes them tick. And payers are really leaning into this. I don't think it's one of those where I don't think patients are going to look at this and say, my goodness, my payer now wants me to be hospitalized at home versus this hospital. I think people want to have care at home. They want to be with their loved ones. They want to be with their pets. They want to be able to walk around and do those things when they can do that. So I think that this is something that is it's really additive. it's a customer service boost. Like I'll tell you, our NPS is north of an 85. If you're in healthcare and you're over a 30, you're doing something right. Like people really love this. So I don't look at it as something that's risky for a payer to do in any way that people are going to take the wrong way. It's another option that a patient can take. And what's really interesting is doctors love it. We're getting tons of referrals from doctors, tons from home health and assisted living facility or communities, I should say, and others, because it really works well. So I don't think there's any risk of that at all. If anything, it's funny. I look at it. I think there's going to be a very smart payer on the commercial side that's going to, at some point in the future, do what I was over at Teladoc many years ago, and Teladoc did a partnership with Oscar, and Oscar went out and did this talk to a doctor 24/7, whatever. And they did great when it came time to annual enrollment. Somebody's going to be really smart here and say, wait a minute, commercial, we're kind of missing the boat here. I can go to these to these insurers, these employers and say, I can replace a $35,000, $40,000 hospitalization with something that's like a sixth of the cost. That's going to play really, really well. Somebody's going to lean into this model and really, really do well. I'm waiting for the first payer to really, I have a lot of payer partners and they're getting really excited about this, but somebody's going to really step up to the plate and really, really push this one like Oscar did. And it's going to be a huge win because employers are hungry for this. It doesn't take a lot, it doesn't take a lot of cases to move that way. And you have control as an employer to send things out to your employees and let them know that this option exists. I think that's going to play really well.
Let's talk a little bit about different categories of patients and whether that's segmented based on their payer or their age or something like that. But I was thinking about sort of the commercial population, which you're just describing. And then I was also thinking about, geriatric, which we talked about a little bit. And then the kind of the overlay with Medicaid or people that are more have less resources. Let's say, for example, those people whose homes are not the best setting for care. How do you think of these different populations? You already started to mention commercial, but maybe lay out how you think about the segmentation and your focus.
Yeah, so I would say if you just look from the ADK or admissions per thousand standpoint, Medicare is always going to be the winner, right? Because older patients are going to have more needs. So I think on an individual member basis, there's always going to be more utilization of Medicare age members. But we are seeing a lot of uptick in commercial and also in Medicaid as well, because there's a ton of value to this. And access to care, if you look at Medicaid, is such an issue. And this really helps to expand the access. So I think all of the above really can do incredibly well. I think we started, and our hypothesis was going to be that Medicare was going to take off like a rocket, and it really did. But now we're starting to see all these other groups really start to catch up. And it's really interesting. And now you're getting more of value-based care. You're getting more groups taking on VBC attribution for commercial populations in addition to MA and others, ACOs, things like that. It's really starting to take off. It's become a really valuable lever for folks. And one thing I haven't mentioned yet, which I think is really interesting, is that patients love this for the reasons I talked about. But with the contracts that I have, patients are paying a specialist copay for this, right? We're billing it as a house call. We may get an advanced rate on that house call. So it's not being billed as an ER visit or a hospitalization. So they're typically paying, what is a specialist copay? $25 to $30, $35, $40, something like that. It's a pretty big win for the patients financially as well.
You mentioned value-based care. Let's talk about that, because that's been something we pointed at for a long time, saying, it makes more sense. You don't just pay for volume, you pay for performance and for outcomes. We've been talking about that for a long time. And during that time, I'm not sure there's been any kind of flattening of the cost curve or improvement of quality or satisfaction. So give me your thought on value-based care and then how it fits in with what you're doing.
Okay. So, I look at value-based care in a couple of different ways. So you've got the VBC where you have provider groups taking on risk, right? And that, maybe you have like an Aetna or United or an Anthem or someone that's pushing risk out to a provider group. I love it, but I think it's challenging for them, right? Because as a provider, you now have your one foot in two different boats. Right. And, I'm just making this up, but 90% of your lives may be fee for service, 10% are value-based care. providers can't sit there and think about, oh my goodness, this one's this and this one's this. They can't think like that. So it's really hard to be able to be successful in that model. We need to see the model speed up more rapidly, I think, for that to actually take hold, because it's almost unfair in a sense for providers to be able to figure that out. I do love where it's going. Where I do think it's starting to take hold and do really well is these the models like your oncology models or your chronic conditions or your home-based care models. I think they're interesting. And I think specific populations like that, I like where that's going. But then you're subcapping out to a bunch of people. I mean, the easiest thing in the world you could do is give it to a provider group, set it and forget it, right? So I think there's a lot of value there. One thing I'll say is we do partner with a bunch of payers, but we also do partner with a lot of these risk-bearing groups or these groups that are taking even pockets of risk. Because, I'll give you an example. Like if you look at, and without talking about specific companies, but if you look at one that's maybe in an oncology space or something like that, I am sure they have patients that are going, all day long for dehydration to the hospital, things like that. Like, why are we doing that, right? We could layer on, you can escalate to us, we can go in there and do that. What about some of these infusions, right? Infusions in the hospital, cost is up here. Infusions in a freestanding facility here. What about infusions in the home? We can help you with that, right? We can help you maximize that site of care. So I think there's a lot to be done on the value-based care side. And, I think its heart is in the right place. I just think it's taking really long to get there. And I think it's because it's hard to have two masters, right? Fee for service and value-based care. And everybody wants to stick with fee for service because it's predictable. Not everybody, providers want to stick with that.
So, Lon, the only place I'll take issue with that, for those watching on video, is what you did in terms of the hand motion, in terms of the cost. And you did like the hospital infusion here, and it's actually up, I think, above the screen.
I was being nice. I was being nice. And to be clear, we have a lot of hospital partners, and I absolutely love working with them. But, they have certain models, and I think they're perfect for certain things. And I think there are other options for other things, right? And it's just like healthcare costs are out of control. I don't have to convince anybody of that. We need to find ways to rein things in some way, shape, or form. And I think site of care optimization just makes a ton of sense, right?
Let's talk about Optum for a minute, because you're obviously familiar there, and they understand the problem and the solution, and even better now that you're left out there and showing them how it's done. Do you think Optum's going to come in and just take your idea and just go faster, even if you do have a good financial partner?
I think Optum would be more of somebody that would want to come in and buy the business. I don't think Optum is a company that's going to go and stand this up on their own, to be very clear. And to be fair, I think, they're owned by a payer, United. I think the payers are in a really tough position right now. All of them, or I don't want to say all, the vast majority of them. Almost all. And, the challenge is they got killed on a risk adjustment with V28. MLR is going up. It's going the wrong way, right? The annual increases aren't what they used to be. All of that, all of them are under pressure. So they're having to make all these cuts and all these changes. They can't do things right now, none of them, that are not highly profitable with predictable margins day one. There's no way they can jump in and do this right now, right? That's where innovative companies like ours come out here. We make a space happen. We do something that's really interesting. Then a company like them or another one wants to come in and say, hey, we'd love to acquire or partner you, because not only is there value in your company, but we're going to plug you into all of our lives, and we're going to make this company exponentially more valuable. And they did that with my old employer, NavaHealth, right? They acquired NavaHealth, plugged us in, got the value of NavaHealth, rolled us out to all their lives, got additional value there, made a lot of sense. But I think there's going to be a couple of years of kind of right sizing and getting everything right at Optum. So I'll say one thing very openly. Anyone that knows me knows that they wouldn't think of me as somebody that would go and work for an Optum. I was acquired and worked for Optum. But I have to tell you, massive respect for the folks there, really sharp people there. I was really impressed with what I saw there. So hats off to them. But I know it's a tough time right now.
So, Lon, last question is going to be about what's happening in this space broadly, because a lot of people realize that the home is where you want to be. So whether it's hospital at home, home health, some various permutations about that. We talked about your initial differentiation, what you're doing quite different from others. How do you sustain that over time to win? Do you see that what's going to happen is that a lot of people are going to copy the model, or you're going to actually have to adapt other pieces that people are doing, or can you keep that differentiation as you grow and potentially go national?
So I think we have a head start. I see a lot of companies that are, like I said, doing urgent care at home or doing waiver program hospital at home. And very openly, we're doing non-waiver, but we could do waiver as well. I've got conversations. If I want to do that, I can do that. So I think we can maintain this differentiation. But at the end of the day, I want to change healthcare. If that is my company driving this, excellent. If there are other folks in other areas of the country that want to stand up and try and make this happen, do it. It's a model that makes sense. It's good for patients. It's good for healthcare overall. I'm a fan of it, right? So we are going to plan to move into other markets, and we can do that on our own. We could partner with other organizations that are on the ground in other markets, or other folks can kind of try and emulate that of what we're doing. I do think we have a lead. I think we're doing things right. But I welcome it, right? I mean, it's let's try and take this to the next level. That's really what I want.
Well, that's it for yet another episode of CareTalk Executive Features. I'm David Williams, President of Health Business Group. My guest today has been Lon Hecht. He's CEO of Care2U. If you like what you heard, please subscribe on your favorite podcast platform. And thank you, Lon.
Thank you, David. It's a pleasure.